So good evening, everyone. So we had a great discussion on myeloma where the role of CAR T cells is really established. Now I'll be discussing about non-small cell lung cancer, where there is a lot of data is coming up, but it is still yet to be an approved therapy in this subset of patients. So though initially we planned it as a CAR T cell therapy, so we have renamed it cellular therapy because TALs have come up as an important player in this scenario. So these are the usual tumor antigens targeted in non-small cell lung cancer. We know that developing a CAR T cell therapy for solid tumor is challenging because of multiple reasons, as you discussed before. I'm not going to those details. So in lung cancer, a lot of antigens are being studied, and you can see many of them are in the early phase trials, and majority in the phase 1 or 2 stages. And we have one phase 2 trial on CA, which is completed. So there's a lot of studies going on, but we are yet to have a robust evidence for cellular therapy in non-small cell lung cancer. So I'll briefly go about each of these tumor antigens. So one is EGFR CAR T cell based CAR T cell therapy. It was a phase 1 trials, and it was published in 2021 from China. So this trial, 9 patients with advanced relapsed or refractory EGFR positive non-small cell lung cancer were included, and they received 2 cycles of piggyback generate, that is non-viral mediated EGFR CAR T cells given at a dose of 1 into 10 raised to 6 or 3 into 10 raised to 6. And 1 patient had a partial response, which lasted for more than 13 months. And 6 patients had stable disease and 2 had progressive disease. The median PFS was 7.13 months and median OS was 15.63 months. You have to remember that this is in a group which is already received multiple lines of therapy. And this CAR T cell infusions were well tolerated with no grade 4 toxicity. Most common toxicity is grade 1 to 3. So there are multiple trials using EGFR CAR T cells which are ongoing, but we are yet to have further evidence on the use of EGFR CAR T. But this phase 1 trial, so it is safe to use this cellular therapy in advanced relapsed refractory EGFR positive patients with non-small cell lung cancer. And a lot of efforts are being done to modify this CAR T cell. One example is chemokine receptors, CCR6 and PD-1 blocking, enhancing the anti-EGFR CAR T therapeutic efficacy. And another antigen which can be targeted is mucin-1. We know that mucin-1 is positive in about 90% of the adenocarcinomas. And there is a phase 1 trial of mucin-1 targeted CAR T cells with the PD-1 knockout through CRISPR for the treatment of non-small cell lung cancer patients. Here they used 1 to 4 cycles of infusions, and it was seen that is manageable toxicity with no grade 3 or 5 adverse events. But the signs of activity was not that great. From the 20 patients enrolled in the study, around more than half experienced stable disease as the best response, whereas around 45% progressed after treatment. And after 1 cycle, the CAR T cell persistence was around 20% at 4 months, indicating that they may require repeated infusions of CAR T. And a phase 2 study is ongoing addressing this question. This was published in 2019. And another antigen which can be targeted is PSCA, that is prostatic stem cell antigen. Though it was originally detected in prostate cancer, it has been found in multiple malignancies like gastric, gallbladder, pancreatic, and lung cancer. In lung, the expression is up to 70%. So it's basically a small glycophosphatidylinosytol anchored cell surface protein. And there are a lot of preclinical studies, for example, tandem CAR T targeting both mucin-1 and PSCA combined with anti-PD-1 antibody, which has expressed potent preclinical activity. And multiple trials are ongoing targeting this antigen in different solid tumors. There's already enough data in prostate cancer, but in other solid tumors also, these trials are ongoing targeting this antigen. And another opportunity to use cellular therapy is something called as, it's basically not a CAR T, it's a T cell receptor therapy. We have discussed before, here the antigen is New York esophagus 1 antigen. So, which is expressed in non-small cell lung cancer in the percentage of 11.8 to 21%. And serum antibody can be detected in around 20% of patients with lung cancers and 23% specifically in non-small cell lung cancer. As this is a TCR therapy, here they've restricted the use to HLA-A2 positive patients with metastatic NY-ESO1 positive non-small cell lung cancer. And 4 patients were there in the study. They received a CAR T cell along with the IL-2 And total T cells at a median of 7 to 10 raised to 9 cells, and with the transduction rate between 36.6 to 96.6. And these are the 4 patients with lung cancer used who were enrolled in this study. And you can see one patient had a partial response, which lasted 4 months, and one patient had a stable disease. Other patients were not assessed for response. So this also gives us a potential role for TCR against NY-ESO-1 antigen. And another antigen which is studied in lung cancer as well as other solid tumors is mesothelin. It is an immunogenic glycoprotein abundantly expressed in non-small cell lung cancer and mesothelioma cells. And it is not appreciably expressed in healthy tissues. So generally, it is correlated with the poor prognosis and resistant to chemotherapy. There's a phase 1 study of regionally delivered autologous mesothelin targeted CAR T cell therapy, basically in patients with pleural disease, where it is given intrapleurally. In this study, mainly patients with the mesothelioma were included, and one patient had non-small cell lung cancer. So intrapleural administration of 0.3 to 0.6 million CAR T cells per kilogram were used here. 18 patients with mesothelioma also received pembrolizumab, and one patient had non-small cell lung cancer. So CAR T cells were detected in the peripheral blood for more than 100 days in around 40% of the patients. And among these patients, median overall survival was around 24 months, and stable disease was sustained for more than 6 months in 8 patients. And 2 patients had complete metabolic response, indicating the promising activity of this CAR T cells in patients with mesothelin expressing tumors. And it was a well-tolerated regimen. So that is about mesothelin CAR T. And another potential target is ROR1, that is receptor tyrosine-like orphan receptor. So this is basically expressed in lung cancer as well as some of the hematological malignancies. And this study used an autologous investigational ROR1 targeted chimeric antigen receptor T cell therapy developed by Lyell Immunopharma. Here there are 20 patients in total, and 16 had a TNBC relapsed refractory disease, and 4 had non-small cell lung cancer. And the mean lines of therapy which previously received was 6. And the overall clinical benefit rate was 38%, and it was around 60% for the TNBC. Adverse reactions were commonest was CRS 60%, pneumonitis 22%, and 17% had headache. One patient had died following this therapy. And the pneumonitis, significant pneumonitis mainly in patients with TNBC who had lung mets. And other patients, the tolerance was fair. And they have used certain technology called as GenR technology, a form of genetic reprogramming intended to overcome the T cell exhaustion, and also APR technology, a form of epigenetic reprogramming, which is intended to generate T cells with properties of durable stemness. And regarding ROR1, it is widely expressed in non-small cell lung cancer, incidence ranging from 30 to 70%. And it can be measured by IHC as well as RNA sequencing and flow cytometry. It is said to be associated with adenocarcinoma histology, EGFR, and young age. So ROR1 is another potential therapeutic target here. And another target is CEA, as we have discussed before. So this is a phase 1 trial of hypoxia responsive CEA CAR T cell therapy in patients with heavily pretreated solid tumors, where they've used intraperitoneal intravenous infusion. And in this subgroup, around 40 patients, one patient had a non-small cell lung cancer. So the IP group displayed a higher objective response rate of around 25% versus 8%. And superior disease control rate was 88% with the IP group, whereas it was 67% in the IV group. And in the high dose group receiving IP infusion, ORR increased to 28.5%. And this patient had response which lasted more than 5 months. And toxicities were mainly CRS in more than 60%, and almost all the patient had hematological toxicity, and bowel toxicity was another issue. So this trial has used IP. Only one patient had non-small cell lung cancer, but other solid tumors, this has shown potential activity. And another important strategy in non-small cell lung cancer is TIL. This phase 2 study making use of the same tumor-infiltrating lymphocyte therapy, which is approved in myeloma, that is lifileucel. And this was published in Cancer Drug Discovery last year. So this is basically an autologous tumor-infiltrating lymphocyte cell therapy. So here, patients with metastatic non-small cell lung cancer who had received prior immunotherapy and progressed on their most recent therapy were included. A total of 39 patients were enrolled, but only 28 could receive infusion because some had progressed in between. And in some patients, manufacturing was a problem. So here, the median number of prior systemic therapies were 2, and all patients have progressed on immunotherapy. And this is a highly unfavorable subset with 10 patients having prior brain metastasis, and close to 50% had prior brain and or liver metastasis. And in majority of the patient, lifileucel could be successfully manufactured using tumor tissue from different anatomic sites, predominantly lung. And the regimen consisted of a preparatory non-myeloablative lymphodepletion regimen with fluci, followed by one-time till infusion and a short course of high-dose IL-2. The median time from tissue harvesting to infusion was 35.5 days. And the toxicity was well in the lines of what is described for this ablative regimen, non-myeloablative regimen and IL-2. And generally, they were as expected and manageable. 2 patients have died of treatment-emergent adverse event. One was due to cardiac failure. Another patient had multiple organ failure, which was attributed to either sepsis or possibly related to the conditioning regimen. So other patients, adverse events are manageable. Coming to the efficacy part, the objective response rate was 21.4%, that's 6 out of 28 patients. And response occurred in tumors with bad biology, like who are resistant to immunotherapy, like PD-L1 negative, low tumor mutational burden, STK11 mutation. And 2 responses were ongoing at the time of data cutoff, including 1 complete metabolic response. So overall response rate, I said it was 21.4%. 1 patient had complete response and 5 had partial response. So here we can see the responses. So 1 patient had CR, and this 5 patients had a partial response. 4 patients had progressive disease. And this green line indicates a patient with a metabolic CR who is still continuing to be having a response. So tumor-infiltrating lymphocytes is definitely one of the most active cellular therapy options in patients with non-small cell lung cancer. And also there is an option of TCR therapy based on the mutations available, which we generally discuss. I have not gone into the details of the same. So to conclude, there are multiple tumor antigens identified in non-small cell cancer, and multiple phases of trials are ongoing. And tumor-infiltrating lymphocytes is definitely a game changer in this scenario, and we are expecting more data regarding the same. Thank you.